Good morning. Let's get started. We're running a little behind, but today, one of our own PGY4 residents, Dr. Adrian Pies, is presenting on the treatment of acute ischemic stroke. So let's get started and try to stay on time. Thank you.
Hi, everybody. Uh, my name is Adrian Pies, and I'm one of the PGY4's adult neurology residents. And sorry for the delay, but let's get started. My presentation today, or ground rounds today, will be on the treatment of acute ischemic strokes, and it will be more like an overview throughout the history and also like what's going on today. Here is the CME code for people that need it. Um, so yeah, let's get started. Stroke is why is this topic for the treatment of ischemic strokes important? Because it's still the leading cause of death in the United States. Actually, it's the number four cause of death, and it accounts for about 1,000, 100,000, 160,000 deaths annually, which is about like 5% of total deaths. And that's like 1 in 20 patients, one in 20 people, actually. Um, on average, someone dies due to stroke in the United States every 3 minutes. So that's again why it why this topic important. When I'm thinking about the uh, treatment of the acute stroke, I'm thinking and like how to figure out like what to do. The biggest things that comes to like my mind is that we need to understand the etiology. So, for example, we need to know that there is existence of blood circulation, and we need to know that there are different types of the stroke, like ischemic, hemorrhagic. Um, Also, what's very important is understanding of the pathophysiology mechanism. So understand that there are like thrombocytes and understanding of the coagulation cascade. And then when we understand these things and potentially another part of the treatment would be having optimal either medications or like instruments that could help us to intervene. And the last thing, even if we have the good understanding and if we have like the instruments or medications to help us with this, we need to have, we are practicing evidence-based medicine. So we have to have like a data supporting our like thought process. So those are the limiting factors when I'm thinking about the treatment of the strokes. Um, so I'll start with the history, just regarding like the etiology. So the stroke was first described by Hippocrates in 400, year 400 before the Christ, and the term that was used was apoplexy, and it was described as sudden catastrophic loss of consciousness, speech, sensation, motion, and it was thought to be due to excess of bile or phlegm, uh, which is consistent with the Galen's theory of four humors, aka humorism. This term was used until 17th century when the UK physician William Harvey published his theory on the circulation of the blood, and the etiology of stroke thought to be the obstruction of the blood getting to the brain. Yeah, back in those times, there was no actual treatment. Everything was basically just like supportive management. Um, Later on, since the 17th century, it was kind of suspected that there are two different mechanisms or etiologies, ischemic and hemorrhagic. However, it was not until 1930s and advances of neuropathology when we were able to confirm the different etiologies. However, even back then, it was still hard to clinically differentiate between the ischemic versus hemorrhagic. Clinically, the differentiation was very unreliable. So then, Another part that's like very important in the like finding out if somebody had a stroke and then like potentially treating is imaging. So actually, initial imaging that was done was developed in 1927 by Egas Moniz, which was like Portuguese neurologist who received the controversial Nobel Prize in 1949 for lobotomy. And he developed also cerebral angiography, which allowed us to kind of see the vasculature inside the brain. However, it was not the best study because it wasn't showing typically like any like acute stroke unless it was like large vessel occlusion, and also it wouldn't reliably show bleeding and yeah, so it provided like very limited benefit. Next step in imaging was air ventriculography and pneumocephalography, which was developed by United States like neurosurgeon in 1980s, 18, Walter Dandy. And it was initially, since he was a neurosurgeon, he noticed that like when air gets into the like ventricles, it basically can, and it's like imaging, it can provide like some information about the ventricles, basically the empty or like a CSF filled space inside the brain. This is the first of this first air ventriculograph that was done, and it was done typically during the neurosurgical procedure. So you needed to have like the burr holes, and then the air would be injected. And here you can see like the um, uh, basically increase the size of the ventricles. It was like some obstructive hydrocephalus. It's from 2018. Um, uh, that was like initial study. Later on, it was like improved. He would inject the air through the lumbar puncture, and then a patient would be positioned in such a like moving thing, and after the air injection, they would be like turned to different positions, so the air gets into all the spaces, and serial X-rays would be done. Uh, Here it's again like the better picture of the initial first ventriculograph, and here you can see like the increased size of the ventricles. You don't see it actually. That's fine. You can see like increase the in ventricles, and here is the how it was set up. The problem with the study was that it didn't give us like much of the information. Basically, it might be good like for the neurosurgeons and their evaluation of like the hydrocephalus and stuff like that, but it didn't show much information about the acute stroke. Another disadvantage were like side effects, which is like a severe headache, nausea, vomiting, and actually, not completely sure about this information, but the data that I found was that it had like up to a 30% mortality rate, which is like if you are going to like diagnose somebody, if the diagnostic study causes 30% mortality rate, it's not the best diagnostic study. So this was like in the early 20th century, and later on, CT scanner was developed in 1970s by Godfrey Hounsfield, a British electrical engineer who received again like Nobel Prize for this in 1979, and it was introduced in medical practice in 1971, and it was a game changer because it provided like a rapid information if the patient has the bleed or there is no bleeding. And then later on, the first MRI was developed, and in 1980s it became like more widespread, which didn't like initially provide much information for like acute uh, treatment of the strokes. However, it provides information and like better information about if there is a stroke. And also like now with the new clinical trials for extended window TPA or like thrombolysis, it's very important study. Okay, so then regarding the treatments, so yeah, since the Hippocrates until like 20th century, there was nothing much that could be actually done like acutely for the strokes. But then after the discovery of anticoagulation, which was like heparin and then warfarin in 1940s, yeah, clinicians began to use anticoagulation for thrombotic conditions, including the stroke. So anticoagulation was trialed mostly in 1940s to 1960s. And the idea was that the stroke means obstruction of the blood flow to the brain. Uh, and basically, anticoagulation will prevent the either extension or like actually dissolve the clot. So at the time, if you remember, the CT scan was like developed in the 1970s. So in this time, in like 1940s to 1960s, we basically didn't have any information about like the character of the stroke. So many times the people with a hemorrhagic stroke were treated with anticoagulation, unfortunately. And then like when there were like clinical trials done to show like to evaluate for the benefit of this treatment, it was basically showing inconsistent benefits. Uh, Antiplatelets, surprisingly, it came after the anticoagulation, which I wasn't aware of. So apparently, the aspirin was developed at the end of the 1890s. However, the aspirin antiplatelet properties weren't discovered until 1960s. So, and then between 1970s to 1990s, there were many trials studying benefit of aspirin in stroke patients. The first trial that was done that's like showing the at least like some signs of benefit is UK TIA trial, which was multi-center study done between 1970s to 1980s. It included 2,400 subjects with a TIA slash stroke. The study was done that there were like three different treatment options: aspirin 600 BID, aspirin 300 daily, and placebo. And basically, those were the patient with a minor stroke or TIA, and they were followed for like 4 years. And it was like evaluated if after those like 4 years they had like some another major stroke, MI, or vascular death. So the main results was a 15% relative risk reduction in major vascular events. However, unfortunately, the study didn't have like strength enough to be yeah, wasn't strong enough. So it was the difference wasn't significant, but it showed at least like some potential data supporting that like aspirin could be beneficial. The breakthrough study for the aspirin was International Stroke Trial in 1997, and then also CAST in the same year, where there were like 19,000 subjects from 36 different countries, and this trial tried to claim if there is any benefit of treatment of the acute stroke with the antiplatelets, with the anticoagulation, and then both versus placebo. Also, the anticoagulation was done by heparin. It was like low and moderate dose. So low was 5,000 units BID, and moderate dose was 12,500 units BID as well. So there were like six different arms because it was like the aspirin alone, aspirin with low heparin, aspirin with moderate heparin, uh, just a heparin low, just heparin moderate, and then placebo. And the outcomes of this study show that there is like 28% reduction in 14-day recurrence of ischemic stroke and 9% reduction in the combined outcome of fatal stroke or death at 14 days in patients treated with aspirin versus non-aspirin arms. There also the best, very good thing about this study was that it evaluated benefit of the heparin, and it didn't show there is any like significant improve of the symptoms, and and it showed increased intracranial bleeding. So as I said, another study was CAST that was done in China. Both were published in 1997 in Lancet, and this was turning point in therapy and prevention of strokes, as it provided robust data supporting the benefit of aspirin early in the treatment. It was like within first 48 hours, and anticoagulation showed increased risk of bleeding without net benefit. So this was like anticoagulation and antiplatelets. Now, regarding the thrombolysis, so thrombolysis was actually discovered pretty early. I wasn't aware of this, but the fibrinolysis, the process was discovered in 1930s, and streptokinase was purified in 1933. First human use of streptokinase was in like 1950s to treat fibrinous pleural exudates and hemothorax. It was not yet for any like cardiac or cerebrovascular accidents. Then in 1970s to 1980s, it got into the cardiovascular medicine. There were large trials that established streptokinase as a standard of care for acute MI. And then also later, after the purification of TPA in 1979, which is interesting, it was known since like 1940s as well as an enzyme, but we were unable to purify it until like 1979. So we had knowledge about this medication for 30 years, but we were just not able to extract it. Um, was uh, was established as a treatment of acute MI. Around the same time, the clinical use of thrombolysis was evaluated also in acute stroke. However, the initial studies failed to show any clinical benefit. And yeah, now I would like to potentially ask you, what do you think? Like, why do you think that the medication that currently we are using as a treatment for acute stroke and its standard of care, why it was not like initial studies didn't show any benefit? What could be like the studies were obviously flawed, but what could be? I'm sorry? Yeah. So one of there were like two big studies that was like ask and must, and yeah, in a must the timing was up to 6 hours, so that's like thought to be one of the contributing factors. Anything else? There's like four things. Yeah, exactly. There was like no standardized dose, and basically we used for the streptokinase, we used the dose that's used at the for MI. Yes, exactly. So initial studies, since we didn't have like CT scan, or even the CT scan that was like available was like very like limited um, um, sensitive. It wasn't like best. Um, I don't know the word, but like the data, it was very pixelated, you know. So and there was also like no central read. There was no like radiology who would be like reading all the CTs. So yeah, initially without a CT scanner, there are many studies where the patients with a hemorrhagic stroke would be actually included. And later on, even when we had a CT study, since the resolution was the word actually, the resolution of the CT scanner didn't provide information about if there is already like hemorrhagic transformation or if there is like some small subarachnoid or subdural hemorrhage. So yeah, basically those were the things. The fourth big thing was that also the size of the stroke. So back then, many studies that were done included malignant like left or like the MCA strokes, which are more tend to bleed. So yeah, basically here it's yeah, the enumeration of these. So the imaging, because the inclusion of the hemorrhagic stroke, inclusion of large infarct cores, excessive long treatment windows, up to 6 hours in the mass trial. Uh, Another thing is concomitant antiplatelet. So that's something that was not established before. And many people who would receive the thrombolysis would be already on antiplatelets. And yeah, then they are more tend to bleed and no dose-defying studies. So this was all before the NAINS trial, which is basically the trial, the big trial that we are still using for um, like support of efficacy of thrombolysis. So NINS trial, or National Institute of Neurological Disorders and Stroke trial in 1995. It's interesting that it was like only 624 subjects. Basically, the study was done. The patients that were included had to be within 3 hours from the symptoms of the onset, and it was two arms, TPA and no TPA. The CT scan needed to be done prior to administration to rule out the hemorrhagic stroke. And the outcomes, it found that there is a 30% increase in minimal or no disability at 3 months. However, there was also tenfold higher risk of symptomatic hemorrhage. Also, this trial kind of supported the whole concept of time is brain, which we are kind of practicing until now. Here are the data that can show nicely how the TPA compared to a placebo was efficient. Basically, for NIH, from 0 to 8, on a placebo arm, there was like about 52% patients. Those who received the TPA would be like over 60%. Modified ranking scale as well. Um, Placebo modified ranking from 0 to 3, about in like 50% of patients, and after the TPA, about 60% of patients, and the same like percentage outcome for Glasgow Coma Scale. Another trial that was done was ECAS 3 in 2008 that showed was used for like extended window thrombolysis. That's basically why we are using it now up to 4.5 hours, actually up to 9 hours with a specific inclusion criteria. And now another intervention that was done was a mechanical thrombectomy. The first trial that was like first positive modern thrombectomy trial was MR Clean in 2015, and then Dawn and Diffuse 3. The first MR Clean was within first 6 hours, and then Dawn and Diffuse 3 that were in 2018. It was like within 6 to 24-hour window. Since then, many things changed, or like there are multiple advances, and basically now I would like to jump to the most recent recommendations where that were published this year. I uh, Here it's like kind of summarized. So the thrombolysis. Now it's basically the studies done on TNK are showing non-inferiority to TPA and also like some benefits. So the TNK is FDA approved for use for acute ischemic stroke. There are also like studies that are supporting like extended window based on like patient inclusion criteria, depending on acute MRI or CT perfusion. And another big thing that was done in this recommendation is the aggressive blood pressure control that was that in the past after the thrombectomy with the complete evacuation of the clot, we would be very aggressive and keeping the patient below 140 of the systolic blood pressure. They didn't show any improvement and actually showed potential harm with the hypoperfusion. So there are like recommendations are not to decrease the blood pressure below like 140 after even like TK3 mechanical thrombectomy. So yeah, those are there are many other things that would be nice to have included here, and yeah, if I had like more time, I would work on that. But this is just like the review of the um, treatments in the past and currently. Thank you very much for your attention. And do you have any questions? Here is the CME code. Yeah. Most important question in stroke? Few seconds, okay? I'll need to think about it. Like yeah, yeah, of course. But I mean, I would have probably like two. One would be like if there are like once the patient comes in with a stroke, what can we acutely do for them to prevent like morbidity and mortality? And second important question in like management of the stroke patients is like how to prevent further strokes from happening. Um, Yeah, I mean that's very very interesting. I think it would be very hard to like with current lifestyle and that we know that like the unhealthy diet, limited exercise and stress are contributing to elevated like blood pressure and everything. It will be very hard to like optimize it, but if we have like I don't know, like some like preventive medications or we are able to make everybody exercise, eat healthy, it would be for sure very beneficial for amount of stroke patients. It's, uh, yeah, so with all the new techniques that we have, like the imaging and like our better understanding of the different etiologies of the stroke, and also different like the patient populations, I think and this is like something that as a clinician I can answer. I think the scientists have like way better and like more interesting answer. But like as a clinician, I would work with the things that we already have. So I think that like the studies that we are doing currently with the extended window of the thrombolysis based on different inclusion criteria or also the new developments in catheters that are used for mechanical thrombectomy. I think that like the things that were not done previously or some dogmas that were that are still here, that like the TNK need or like the thrombolysis needs to be within 4.5 hours, or like the we cannot go after like I don't know like M2 M3 occlusions. With all of these advances, I think that something if we have proper inclusion of the patients that, like who would qualify in the next 10 years, that's what I can see as a clinician. I think like some scientists would have like way more like breakthrough answer to this though. Yeah, the standard guidelines the are of course like the moderate well limiting or the management of the risk factors. So like the diabetes, hypertension, hyper cholesterolemia. So like having the LDL before like below 100 or like below 170, having A1C before below like 6.5, and having the blood pressure like being like normotensive, unless there are like some occlusions with severe stenosis. And then like a Mediterranean diet, moderate exercise, good sleep. So those are all the uh, no smoking, ideally no alcohol. Those are all the things that are easy to say and hard to actually do for many people, including me. Like for example, eating healthy. But those are the main preventing factors that I am aware. Yeah. To be honest, I'm not completely sure on like how much exercise. Um, that's also a very good question, and I'm not completely sure the definition. Yeah, yeah. Yes. Yes. Okay. Okay. Yeah. I mean, so like aspirin itself has like some like side effects, and like one of those would be like the bleeding, either like GI or like potentially even like if it's like mildly increased, that then since not everybody throughout their life have a stroke, I mean, you will be treating many people who eventually wouldn't ever have a stroke with some medication that potentially can cause some harm. So I guess that's like I just thought about it for 10 seconds and this is my answer. I would need to think about it way longer, but this is like the first thing that comes to my mind a little bit. What do you think? Any other questions? Thank you very much for your attention.